Welcome to Decoding Healthcare Research, a podcast by Agora Project. Join us as we delve into the behind-the-scenes world of groundbreaking research and the dynamic healthcare industry, interviewing top paper authors, engaging experts on industry-related topics, and exploring medical subjects that affect our daily lives. And now, your host, Dr. E.F. Rain.
Welcome to Decoding Healthcare Research. I'm your host, Efrain Riveros, Dr. E.F. Rain. In this episode, we will talk about high-dose vitamin C and its role in cancer therapy. Today, we have a very special guest. We have Dr. Connie Jimenez. She's a professor of Translational OncoProteomics at Amsterdam University Medical Center, where she is the head of OncoProteomics Laboratory. Welcome, Dr. Jimenez.
Thank you very much. My pleasure.
Perfect. Excellent. Thank you so much. So the discussion is going to be centered on a paper that was published by Dr. Jimenez in 2021 in the Journal of Experimental and Clinical Cancer Research. The title of the paper is High-Dose Intravenous Vitamin C, a Promising Multi-Targeting Agent in the Treatment of Cancer. So I guess my first question is, what sparked your interest in vitamin C as part of treatment in cancer?
Yes, thank you for this question. Well, my fascination for vitamin C started some years ago, actually when I discovered in my own life that vitamin C was very beneficial for my own health. And then I started, so this was kind of empirically, and then I started reading up on vitamin C, and then I discovered that vitamin C is this very essential molecule. It's actually maybe not a vitamin, but a hormone, because other animals and in the plant kingdom, the cells can make their own vitamin C, and it has widespread biological functions. And all our cells in the body have vitamin C receptors or transporter mechanisms. It's the most important antioxidant. So this kind of sparked my interest. And then I discovered this whole literature around vitamin C as in high dose as an anti-cancer treatment. So that's kind of when I started reading more. And then there are so many beneficial effects and then these therapeutic effects. And me as a cancer researcher, it was almost too good to be true. So then I did, my lab is based in a medical oncology department of the Amsterdam University Medical Center, academic medical center. So then I did a brainstorm evening at the department staff evening. And then basically most of the oncologists, they were not aware of all these beneficial effects of what vitamin C basically can do as an anti-cancer agent. And then that's when I decided, okay, I want to do more research myself in the lab. And also I want to summarize all the literature out there because there was so much out there. And also a lot of literature where vitamin C is combined with standard of care chemo radiotherapies and can be very beneficial, both in the sense that it can synergize with the standard of care treatments and also counterbalance the toxicity. So I thought I should write a review together with, I did that with a Ph.D. student postdoc in the lab, Andrea Valles and Francesca Böttger. To also we made an effort making comprehensive figures, so to make it really easy for, let's say, oncologists to look up whether their favorite drug combination is in there, to kind of summarize all the preclinical and clinical research.
And it's interesting because actually it called my attention for a similar reason. We are exploring in our podcast adjuvant, let's call it alternative therapies to different diseases, in this case, cancer, the role of non-pharmacological therapy that is promising, especially because the clinical results with the traditional therapies is falling short in some cases. So there is a call for for finding new ways to approach the disease, and this fits perfectly in that framework. So my first impression when I started going over your paper and other papers is that the effectiveness of vitamin C in the context of cancer happens only with the high intravenous doses. So what is the difference between oral and IV? Is it just bioavailability, or is there something else behind it?
This is a very important point. Orally, the plasma levels can go up only to about 220 micromolar in blood. And with intravenous vitamin C, we can go up to in the millimolar range, and target value is at least 15 millimolar up to 30 millimolar. And these millimolar concentrations, they can kill cancer cells. So it's only in the millimolar range that cancer cells are killed. And we've seen that in vitro too. We've tested 55 cancer cell lines, different cancer cell lines. And they were all killed in the either high micromolar range to low millimolar range. So all the 50, or actually 51 cell lines were killed at clinically achievable doses. So we really need these high doses in order to get cancer kill. And in high dose, for the cancer cell, vitamin C acts as a pro-oxidant. And this is how it works. And this is, I think, what people would not realize or think about vitamin C. But in a very high dose, it can act as a pro-oxidant. And it's basically targeting the redox imbalance in cancer cells, specifically in cancer cells, because cancer cells have a lot of oxidative stress, a lot of, it reacts with the intracellular reactive or labile iron pool in cancer cells. So and thereby it can create more oxidative stress in the cancer cell.
So when you mention high dose, how much is that? And to put it in context, what is the daily requirement of vitamin C compared with the dose that you need for cancer treatment, and how often you have to do it?
Yeah. So in the when we do, let's say, oral supplementation for health, then we're talking about maybe I would say a gram dose, just 1, 2, 3 grams for prevention purposes. And that's kind of extrapolating what other animals can make in their bodies. If we calculate that to humans would need at least 1, 2, 3 grams over divided dose in a day. And then what is given as anti-cancer treatment intravenously, our dose is at least 1 gram per kilogram. The most effective doses are like 1.5 gram per kilogram. So then we're talking 70 grams for an individual of 70 kilos, up to 100, 150 grams. That's what given in a single dose infused during 1 or 2 hours. And this should be done ideally as well. The studies that show benefits, also some signs of efficacy, did the dosing 2 to 3 times a week, at least for 2 or 3 months to have really this effect. And there is a couple of monotherapy studies out there. And then I would say at least 3 times a week, and more is better, and longer. And the longer it can be done, the better. So maybe at least if you're combating advanced cancer, you would want this ideally then at least for a year. But most people do it as in combination treatments with standard of care chemotherapy or other therapies. A lot of therapies have been tested. So this is more in the metastatic out of option setting. And then studies also show benefits with 2 times a week, these kind of high, let's say, pharmacological doses of ascorbic acid or vitamin C. And I think the 2 times a week is probably more for practical reasons, because then patients come in to get their other treatment and then they get the vitamin C.
I see. And you mentioned that when vitamin C has been used in the clinical settings, is part of a combination treatment, probably with chemo and radiotherapy. That's probably the importance of preclinical studies. And my question is, in preclinical studies, has it been used by itself?
Yes, in preclinicals, there's many preclinical studies that tested it by itself. I mean, we in our own study, it's submitted. We're submitting this now for publication. We'll put it out on bioarchives. In our own study, we only used vitamin C as mono treatment, and it can. I mean, it can kill cancer cells just like it's chemo. I mean, it's very surprising.
Effective.
So for one of the cell panels, so we had multiple. We had breast cancer, prostate cancer, lung cancer, pancreatic cancer, colorectal cancer panels in this 51 cell line set. And for the lung cancer cells, we also tested them with cisplatin. So we have the data, the IC50 data for the high dose C and also for cisplatin. And I mean, there's no difference. It looks like chemo and the interesting thing is, so there are cells that are pretty resistant. There were in this panel non-small cell lung cancer cells that were pretty resistant for cisplatin, but very sensitive for high dose vitamin C. And there is, you can then that to kill that cell would be really beneficial to use the combination, or for that particular cell line, vitamin C alone could really do the job.
And when you mentioned that in cell lines is very effective, then it comes to my mind, if you eventually we translate this into either animal models or patients, let's talk about a little bit about the side effects, because one of the problems with the chemo and radiotherapy is the magnitude of the adverse effects. So what are the adverse effects of vitamin C?
Well, if we look at all the literature also that is in our review, there are no side effects. It's very safe. All the conclusions in all these clinical studies are it's very safe and it's very tolerable, and it can counterbalance toxicity of the chemo. And I should emphasize that all the studies are the clinical studies are early phase clinical studies, so they're all phase 1, phase 2 studies. So they were not powered for efficacy, but some of the studies, they have like a signal of efficacy, because then the people live much longer than you would expect based on historic data of comparable populations. For example, there was one of my favorite studies was published in Cancer Cell in 2017. And that's a study in glioblastoma and non-small cell lung cancer. And in that study, they go from cell lines to animal models to a phase 1, phase 2 study for GBM and non-small cell lung cancer. And for lung cancer, it was combined with platinum-based chemotherapy. And in the GBM study with radio chemotherapy based on temozolomide. And basically there are no downsides. There are only upsides. So that's why I really think oncologists should take a good notice of this, and because they can help their patients much better if they include vitamin C in their arsenal of treatment options, and then most preclinical studies show synergism, so that's very interesting. So potentially the chemo doses used in the clinic could be reduced if the high dose if combined with high dose C, because it basically you're combining two pro-oxidant compounds, but one has no toxicity, the other one has, but together they can synergize, and then maybe the dose for the toxic one can be a bit lower.
Correct. And regarding the type of cancer, because cancer is a multifaceted disease. Not all cancers are created equal, and the nature, the natural course, and the biology behind it is different. So, what do you think are the cancers that are more responsive to vitamin C?
Yeah, so based on our own preclinical data with the 51 cell lines, they could all be killed in clinically achievable range. It was clear that some were more sensitive than others. Some had IC50s in the I think the high micromolar range, or some even low micromolar range, and the highest one was 10 millimolar. But I think what is great from the literature and also the clinical studies, they show that even the very hard to treat patient populations, for example, with KRAS, BRAF mutant, KRAS mutant tumors, that they also have benefit. And there is also one study that was published in Science some years back in colorectal cancer, preclinical model, genetic mouse model, showing that actually the KRAS mutant tumors were even more sensitive than the non-mutant tumors. And but there are other studies that show in patients that equal benefit from in colorectal cancer from KRAS mutant or wild type. I know, so I would say this is like a could be a one size fits all therapy. Because even the ones that are, so I don't call them resistant, I call them less sensitive. Also, the less sensitive ones can be at least in vitro IC50s are well below clinically achievable dose or concentration range. That's 15 to 30 millimolar. So if the IC50 is 5, it's well below that.
Now I want to dive on the molecular mechanisms of vitamin C to help in cancer treatment. In your paper, you classify it very nicely. You talk about pro-oxidant activity, also cofactor activity, and immunomodulation, and some other effects. Can you elaborate a little bit more about the different molecular mechanisms involved?
Yes. So the most well-known, well-established, and many studies that have now reported this is the pro-oxidant effect of high-dose vitamin C. So thereby it directly acts on the cancer cell, interacting with this altered cancer metabolism. Cancer cells have defective mitochondria. They already have increased oxidative stress because they are their antioxidant defense with the catalase enzyme is much reduced, and this is and they have these increased labile iron, and then vitamin C can also be taken up in oxidized form through the GLUT transporter protein. So the cancer cells have high expression of the GLUT transporter to take up a lot of glucose, and vitamin C in oxidized form is taken up by this GLUT transporter. In non-oxidized form, just normal form, there are specific uptake mechanisms, but I think the nice thing with cancer cells is the oxidized form of vitamin C can go in via the GLUT transporter, and this is like a Trojan horse, because then inside the cancer cell it's reduced again, and then it depletes the antioxidant defense even further. So some studies also show interaction with this inhibition of glycolysis, but altogether these interactions cause hydrogen peroxide radicals, oxygen radicals inside the cancer cell, and that's what then kills it. So this is the direct effect on the cancer cell. And then we have cofactor activity for many proryl hydrolyse enzymes, so that are involved in a lot of different biosynthetic pathways that are then beneficial as a let's say secondary effect. So the collagen synthesis is a very important one. So for stable, strong, and collagen, this is of course relevant to impede cancer spread. And then vitamin C is needed for the enzyme that does hydroxylation on hypoxia-inducible factor. So it's important for the activity of a HIF and also the degradation. So of course, this HIF is a very important molecule to inhibit, because thereby the blood, because HIF triggers the angiogenesis. So this whole process is inhibited by vitamin C. It can reverse epithelial-mesenchymal transition, which has been implicated also in cancer spreads and poor prognosis. And the studies in pancreatic cancer focused on EMT reversion as one of the mechanisms. And in many studies in leukemia especially, show the important effects of vitamin C to reverse aberrant DNA methylation through TET activity regulation. That is also part of the cofactor activity functions of vitamin C. And thereby tumor suppressors like p53 are re-expressed. So this is also very important. And then we have, I think, last but not least, the immune modulatory effects. So these are also secondary effects, and they may not need this very high dose. Possibly high oral doses could already be doing the immune modulation. And so because vitamin C there's many affects both the innate and the adaptive immune system. Also, the highest concentrations of vitamin C in our body are in lymphocytes, next to the also pituitary, adrenals, and the eye. Vitamin C is very important to protect the lymphocytes from their own oxidative radicals that they use to kill microbes and so. The cofactor activity of vitamin C in the immune system has all kinds of roles in the proliferation and the maturation of all these different cell types. It has been implicated in chemotaxis, cytokine production, natural killer cell cancer killing. So it's crucial for immune function. And of course, our immune system is very important defense line against cancer. And what is also very interesting is that there are two recent studies, preclinical studies, that show that vitamin C can synergize with immune checkpoint inhibitors in mouse models. This was shown. And it's very important. These mouse model studies also show that the benefit from high dose C can be seen much better in the immune competent mouse setting. So the mouse with a functional immune system have much more benefit of vitamin C. So that also indicates that the effects are both the cytotoxic effects on the cancer cells, but on the other hand, the immune boosting effects on the immune cells. And I think we need both, of course, to get an effective reduction of tumor growth.
Yeah, and I see that the evidence is very compelling. As you presented in your paper, is not one or two papers showing evidence of effectiveness. So it's really something to pay attention to. So my question is, what do you think are the roadblocks or the obstacles for vitamin C to become mainstream among oncologists, and how do you envision the vitamin C research and clinical application to move forward?
Yeah, what we see in the literature, in the clinical studies, the phase 1, phase 2 studies, they all end their discussion saying further large-scale studies are warranted to determine the overall efficacy of high-dose intravenous vitamin C. So a phase 3 studies are needed, and that's basically where up till now it stops. I think there's one phase 3 study in the clinicaltrial.gov database in China that was formulated as a follow-up of a successful phase 2 study. But I think, yeah, so I don't think it's lack of encouraging data. It's not lack of preclinical data. I mean, there is a huge wealth of data, and there's a lot of phase 1, phase 2, early stage clinical studies. And of course, we have decades of experience in the complementary health setting. For decades, these practitioners are giving IVCs to help their patients, usually as a supportive adjuvant treatment. So there's a lot of clinical experience. We know it's safe, it's tolerable, it's not expensive. But maybe one problem is it cannot be patented. And when things cannot be patented, who will pay for these large-scale phase 3 studies? I think the hospitals, they are kind of able to do the phase 1, 2 still out of their own pocket or with some little grant money. But for the phase 3, more serious money is needed. And yeah, that requires more effort to find the money. And I think, so this is needed. And I think we need some kind of different model because, pharma will not push this. So who will? So I think cancer foundations, maybe governments, but I think it also starts with making this more, making oncologists aware that this exists. Because from my staff brainstorm evening that I did some years back, I discovered that the oncologists did not know. And that's so I hope that this review article that we wrote, and also I'm so happy to be on your podcast, to create, that the clinicians learn about this, and also that patients know about this. So I think if both clinicians know and learn that this can be very valuable part of the toolbox to help their patients. And when patients can also make, this happens now already, patients go with my article in their hand to their clinician and ask for vitamin C high dose. And sometimes I get questions, where can I get it? I also sometimes get questions from oncologists to learn more. So I think that's all very positive, and then hopefully we get the phase 3 studies at some point.
Yeah, and actually one of the goals of this podcast is to spread the word about valuable research, and this is definitely one of them. And along the same lines, what would be your advice for clinicians who are interested in learning more about vitamin C? So what resources are available for people to get deeper into this? Because I think this is getting momentum, in my opinion.
Yes. Well, I know that one clinic in the US that does a lot of IVCs, that's a Riordan clinic. They make their IV protocol available on their website. So that's one place, and they have the protocol also in Spanish, in English, in Spanish, and I think one more language. So actually, I recently there was a Spanish oncologist asking me, And then I sent him the translated protocol. And that clinic has been doing IVCs for several decades. So I think they probably have the most experience on the clinical side. And I guess the people doing clinical trials, they also know how to do it. So I would say clinicians, look up which clinical trials were done, and I mean they probably share their protocol too. But I think the Riordan Clinic protocol is good to have.
Excellent. And going back to your lab and your research group, what's coming next? What are you guys researching in this along the same line?
So my lab, we use proteomics to understand the biology of cancer and identify biomarkers targets. And I am with mass spec-based proteomics. I also want to contribute to the understanding of how vitamin C works. And and we work on personalized, let's say, single sample precision oncology pipeline. That in order to we have a focus on to use proteome and also phosphoproteome profiles to select the best therapy for individual patients. And we have a big focus on kinase inhibitors. So based on phosphoproteome profile, we can rank kinase activities in single tumors. And based on this, we can, you can match then the kinase, the hyperactive kinases to matching drugs that can target that. And we found that in low dose kinase inhibitor combinations can also work to kill cancer cells. And I'm also very much interested in combining that with high dose vitamin C. We don't know exactly how, in what sequence to do that. I mean, there's more work to do there, but also I got interested in this because there are preclinical studies that combined single kinase inhibitors with high dose vitamin C. So that is an area that I think is also very interesting.
Yeah, and it's exciting, and we are definitely following up on your results. I think that having this discussion is important because it raises awareness. And the way we presented it today, with you explaining the molecular mechanisms, the evidence behind it, and the promising results, is something that is definitely interesting for our audience. And I think that way we can wrap up our conversation. First of all, thank you very much again for sharing. Yeah, go ahead, please.
Yeah, I one more thing comes to mind. So of course, immunotherapy is now a very big, important therapy, and gets more and more important. But still, there is a lot of patients who do not benefit from immune checkpoint therapy. And here, high dose vitamin C, I think that is very promising because it can make cold tumors hot, like chemo can do. So I really see also the future should really look more at combinations of immunotherapy and high dose C, or the triple combo: immunotherapy, chemotherapy, and high dose C. So I think the triple combo could also, maybe that in the end will be a great one-size-fits-all therapy for all cancer patients with advanced disease.
And this is very relevant because the immunotherapy is included in more and more protocols for both solid and non-solid tumors, and I think definitely vitamin C has a role to play in that context. And that's,
because if it can synergize on one hand with the chemo and on the other hand with the immune therapy, then I think that would be maybe the dream therapy that then can really eradicate, not just prolong life, but eradicate the cancer.
Yeah, that's absolutely true, and it's definitely something very, very exciting. And I'm excited to having had this conversation. And as I told you, we will follow up on your results, and from other sources as well. And I hope we can talk again in the future and see how this particular topic is progressing and being more into clinical practice. Thank you very much, Dr. Jimenez, for your time and for sharing your knowledge with us. And for our audience, you will find the links to not only to this paper, but other papers from the group of Dr. Jimenez. And don't forget to leave us your feedback about this podcast and about podcasts and topics that you want to listen to in the future. And see you in the next episode. Thank you, Dr. Jimenez.
Thank you very much, Dr. Efrain.
Thank you so much for tuning into this episode. If you enjoyed it, please don't forget to give us a thumbs up and share it with your friends and family. Make sure to subscribe to our channel and hit that notification bell so you never miss an episode. If you have any questions or thoughts about today's topic, we'd love to hear from you. Feel free to leave your comments down below. For more information and references related to today's discussion, you can find them in the video description below. We appreciate your support and look forward to having you back for our next episode.